over to you, sir.
Thank you, ma'am. Thank you. And thank you for the opportunity. I hope I stick to time, and if I don't, I'll just cut my slide short then. Until this is playing out, I think just wanted to make a couple of quick points regarding what has already gone by. So we at PGI in Chandigarh, our rheumatologist colleagues do offer TPMT prior to azathioprine to most patients who can afford it. It's not that if patients don't get it done, they are not started on azathioprine, but yes, if the enzyme's not there, then they do not give them azathioprine. So we've been doing TPMT, offering it to all patients, but 10 to 20% patients are the ones who are the actual takers for it. But we do offer it to all patients, again, solely based on our experience with our rheumatology colleagues who we work very, very closely with. And one more point before I get into my talk, I think this is regarding that headlight in the fog case, that pediatric tuberculosis/toxo. So to my mind, we'd actually published from PGI about 4 years back now of pediatric tubercular uveitis in ocular immunology inflammation. If you were to go through that, you'd actually see a couple of cases illustrated very similar to the ones that you had. So pediatric tubercular uveitis is different, and without wasting too much time, just would like to, with folded hands, suggest everyone to go through that paper, and I think the answer to that conundrum in that case would be solved. And with that, I come to targeted biopsy in uveitis. If I can get it to work. Yeah. Yeah, thank you. So biopsy in uveitis could be a targeted extraocular biopsy. If it's not extraocular, it could be extra, as in it could be a conjunctival biopsy, it could be an AC tap, aqueous, it could be a vitreous biopsies, subretinal, chorioretinal, it could be a diagnostic enucleation. So a targeted extraocular biopsy is typical if you want to diagnose someone as having sarcoidosis, or with tuberculosis. You could do, depending on your signs in the eye, request the pulmonologist to try and take a sample from various different sites in the body, and that can help. I think most of us know that. Again, quickly, going past just a small example of how an ocular exam can actually dictate a targeted extraocular biopsy and lead to diagnosis. The 35-year-old male had a gradual, drop in vision, 6/18, both eyes, had family history. His father had died at a very similar age. He had multiple neurological issues, his supinator jerks and ankle jerks, and all of those were off. And this is what he had. He had, I don't know whether it's showing up there or not, but had, typically if Dr. Somshila were here, she'd actually be able to point out those sago grain-like deposits. They were actually there in both the corneas, had those typical glass wool-like opacities just in the retrolental space, and did not have, the media was grade 1, but had what looked like a very, like a very moderate NPDR kind of appearance on fundus examination. And long story short, we actually got the, our clinical suspicion was amyloidosis. The patient underwent a fat pad biopsy, abdominal fat pad, which was negative. A sural nerve biopsy, however, showed that this patient had, FAP. And although we couldn't do much for him, but just to show how a targeted ocular examination can also lead to, at your behest, a targeted extraocular biopsy, which might lead to a particular diagnosis, and not beating around the bush. A conjunctival biopsy, again, not getting into how it's done, or what it could lead to, because I want to focus a bit more on the retinal and the vitreous biopsy. But this patient actually had rheumatoid arthritis, also had stage 0 CLL. However, the biopsy actually showed. I'm going to just skip to this. You can actually take a biopsy out of those, from that fleshy area, and the entire prognosis and the staging of the CLL changes. Coming to the indications of vitreous biopsy, vitreous, subretinal, or chorioretinal, if time permits, in uveitis, which is quite frankly my specific area of interest. So you can have the indications for vitrectomy in uveitis can be diagnostic, therapeutic. We're not looking at the therapeutic ones for the purpose of this talk. Basically diagnostic ones, and you typically want to enter the vitreous cavity if there is diagnostic dilemma despite clinical exams, serological tests, and imaging, or there is a very high suspicion of an infective or a neoplastic etiology, or there is rapid deterioration of vision despite despite what you think you're doing right. And the outcome is not marrying with what you think is the diagnosis, or you have unequivocal or ambiguous diagnostic vitrectomy results, then you want to go a step further and maybe incise or excise a part of the retina. Just going to skip that. This is some of our published work on this topic. I'm just going to come to one case, and hopefully through this try and show how a diagnostic vitrectomy works. This patient was suspected of having a primary vitreoretinal lymphoma. You can see the amount of vitreous haze. The initial vitrectomy is begun under air infusion, because you want a diluted vitreous sample. The cut rate is reduced to 800 cuts per minute, and about 1.5 to 2 ml of the initial vitreous is actually taken out and aspirated under air for an undiluted vitreous sample, following which the BSS is switched on, and then you can take a bigger sample of the vitreous and actually clear up the whole amount of the vitreous as you do. You also need to induce a PVD, which I haven't shown in this because of lack of time. And in this patient, I had this dull yellow patch just temporal to the fovea, which will be soon seen on the blown up image. And I actually went ahead and taken a subretinal biopsy, which is fairly simple to do. Just a routine endocautery, and then using a passive soft tip attached to a 2 cc syringe. And mind you, passive, not active extrusion attached to the machine. And you enter with that into the subretinal space and passively allow the cells to walk up through the capillary, via the capillary action into the hub of the 2 cc needle. And what that does, I think I'll be showing in the subsequent slides. So that is basically that. And you, do a fluid head exchange, do endo laser, and I close this patient with 18% SF6 gas tamponade. So typically, both the undiluted and the diluted vitreous show that, those amount of cells, which are scanty, right? And the subretinal aspirate, the one that I've taken, had shown, actually shows that. So not only is the yield more, but the morphology of the cells is very well maintained. Hence, no ambiguity in diagnosis. And you can go ahead and stain them with appropriate stains. And this patient actually turned out to be CD20 positive and had a diffuse large B-cell lymphoma. So this is one of the ways and a few of the steps that you need to do to take a vitreous and a subretinal biopsy. And if time permits, this maybe would be my last case. And I'm going to show how you might want to take a chorioretinal biopsy in certain exceptional circumstances. This has some kind of video. So this patient actually presented to us having been given Ozurdex elsewhere. And this patient, I think, at the outset had infectious retinitis, which with Ozurdex in the eye, it just spread all over. I'm just going to finish in 1 minute. And by the time we took this patient up for vitrectomy, you can see there is so much of wet heme, and all of that is the hyaloid, which is fibrosed and thickened. And it looks like you're almost cutting the retina, and this is not a uveitic case, but a diabetic case, but trust me, it is a uveitic case. So after cutting that, thickened hyaloid and trying to get, some semblance of view of the retina, which you'll soon see that I was able to get, then you try and locate a junction which is extramacular, but involves a part of the active, retinitis. So that you can see is the optic disc that I'm passively, getting the blood off, and all of those are the multifocal areas of necrotizing retinitis. I did some laser in the area that I did not want to excise first, and then settled on one of the areas there, which I wanted to excise just half a minute and then through, and actually earmark it with a mixture of cautery and confluent endo laser. And so it was actually, part of the tissue was healthy, was what looked like healthy retina, and part was the diseased retina. Made a separate port, went in with a 20 gauge old school vertical scissors, and actually cut out part of the, again, as I said, what clinically looked like diseased and non-diseased retina. And this patient did go on to show that this had toxoplasma. So just going to not look at other causes of, other things on that. Thank you.